you, there's a special place in heaven. And I think if anything, COVID has taught us that there is absolutely a special place in heaven for all the great work that you guys have done and continue to do every day to help us get through this. So with that, what I'd like to do is I'd like to start and call on Daniel, if you can introduce yourself for the audience, that'd be great.
Thanks so much, and thanks for having me, and thanks to New York State HIMSS. I'm Daniel Barchi. I'm the Chief Information Officer for NewYork-Presbyterian. We are a 10-hospital system and based largely in Manhattan and the boroughs in Westchester, and we're also the teaching partner for Columbia and Cornell.
Thank you. I'm not sure if we've got John on the call yet. I know Sebastian's working on him, so what we'll do is he on the call?
I just joined. I apologize.
That's okay. If you could introduce yourself, that'd be great, John.
Okay, sure. And I'm sorry that I'm not on video, having some technical difficulties. John Bosco. I'm the Senior Vice President and Chief Information Officer at Northwell Health. Northwell Health is a large integrated delivery system that's based in the New York City area with about 23 hospitals and 800 ambulatory practices in the New York City, Long Island, and the suburbs of New York City.
Thank you, John. Okay, let's go to Robert. If you can introduce yourself, that'd be great.
Hi, I'm Robbie Freeman. I'm the Vice President of Clinical Innovation at the Mount Sinai Health System. We're an 8-hospital health system located in New York City. We're associated with the Icahn School of Medicine. We also have a School of Nursing. And thank you to HIMSS New York for hosting this event and for having me here today.
Thank you, Robbie. Let's go to Yuri.
Hi, my name is Uri Betesh, and I'm the CEO and founder of Dados Health. Dados is a remote care automation platform. What we do is we've developed software tools to embed remote care processes into existing clinical workflows for providers and pharmaceutical companies. Thank you for HIMSS New York for having me.
Thank you, Yuri. Tom?
Hi, thanks, Joe. This is Tom Moore from Healthex. I'm the SVP for Innovation. Healthex is a public HIE in New York City and includes about 2,000 participating healthcare organizations, including 3 of my fellow panelists' organizations. We house data on about 20 million active patients at 8,000 facilities in the area. We're the largest HIE in the United States. Innovation is responsible for working with our participants to identify their business and clinical needs and implementing those services at their organizations.
Thank you, Tom. So here's how this is going to work. We've prepared some questions.
Sorry, Joe, just before we get started, I just want to show the audience how they can ask questions, and then I'll hand it back over to you. So everyone on your, no matter how you've joined this webinar, you have a CC button if you'd like to turn on closed captioning, which is done by AI, so it's not perfect, but pretty close if you'd rather read than listen. But the more important feature is the Q&A function. So if you want to ask questions at any point during this webinar, just click that little icon that looks like a question mark on the right-hand side. You have a choice to ask questions anonymously, or you can enter your name if you want us to see who's asked the questions. And if you run into any technical difficulties, I recommend you click the meeting link back into a browser and just refresh the browser, and that should restart the live stream if it ever stops. Back to you, Joe.
Thank you, Sebastian. Yeah, I apologize. I didn't need to step on you like that. I just wanted to say the way this works is I'm going to moderate this panel, and we've already prepared a lot of questions. So we're going to get through some of them and get the ball rolling here, but really, we hope that you all participate and follow that instruction and click on and give us some questions. We certainly want to make this as interactive as we possibly can and look forward to hearing some of your questions as well. So Daniel, we're going to start with you. Unlike other states across the nation, COVID-19 really snuck up on the New York and New Jersey healthcare communities with respect to the contagiousness and complexity of this flu. This required us to all go well beyond anything our incident response plans could have ever imagined. Can you tell us when you and your organization first realized just how bad this would be, and your initial response or task that helped you and your staff and your organization begin to start to deal with this?
Sure, thanks for asking. Looking back on it, I'm so glad where we are now relative to where we were in March and April and May. And you used the term snuck up on us. I remember that we were actually watching closely what had been happening in China, and especially in Italy, as markers for what to expect. So we were on the lookout for early cases, and in our case at New York-Presbyterian, our first case was at our New York-Presbyterian Lawrence Hospital in Westchester County, and we identified that case, and then we knew to be prepared for more. In the first 2 weeks, we saw the numbers climb slowly from 1 to 5 to about 15. But to your point about being prepared for it, we knew that we were going to have to be prepared for something like we'd never seen before. And so early on, we established our incident command center team. We had a virtual command center going 24/7. And the thing that I'd point out was probably most helpful for us, given that at one point we got to as many as 2,500 COVID positive patients in-house in our hospitals and more than 800 patients on ventilators, was that early on we canceled our elective surgeries. So that's not something that the state had mandated at that point. Our chief operating officer, using analytics from our team based on Wuhan and Italy models, predicted what the growth would be pretty accurately. And so it was the analytics that allowed her to know the growth we should expect, and made that decision in early March that we needed to start converting our ORs into ICUs. Now, everything that followed, I'm quite proud of. The ability for our biomedical team to turn PACUs and ORs into ICUs, the innovation of our physicians to put multiple patients on one ventilator, the way that our finance and logistics team lined up ventilators and everything that we needed. But it was that early decision by our chief operating officer to stand up our incident command center, and the decision when to cancel elective surgeries, I think, is what put us in a very good spot.
Thank you, Daniel. John, if you could take that question, that'd be great.
Sure, and I think the answer is similar to Dan's. We were all sort of in a similar position, being in the heart of New York City. It was really watching the locations that he mentioned that really gave us the early warning signal. And then again, not very far from where I live in the suburbs, in New Rochelle, we had one of the first outbreaks, pretty big outbreak, and that really clued us in that this was going to be maybe worse than we thought. So we did stand up our incident command structure right away. Interestingly, we didn't go virtual right away. We thought we could do it the way we've always done it and the way we rehearse every year, and put a lot of people in the room, a lot of leadership people, and it turned out somebody in the room tested positive, and actually a few others that were sitting alongside him during those early long days, and we quickly thought, oh well, this isn't going to work, and so we went virtual very quickly. But it was, a standard response in the beginning, and then, I really think this was a sort of continuous learning experience and something that we weren't necessarily prepared for, even though we believe we are very, that emergency management's in our DNA, but for nothing like this. And so we were just literally day by day understanding what the next things were to do. We did, as Dan said, a lot of repurposing of PACUs and ORs, and in addition constructed 2,000 additional beds in our hospitals. We literally took every inch of space, whether it was training rooms, administrative offices, hallways, anything that we can find. We have a normal census of about 3,300. In any given day, we wound up with about 3,600 COVID patients at the peak in that first week of April. And in order to accommodate that, we literally built beds in all the hospitals, and that's what allowed us to really get the people in the door that needed the treatment.
Thank you, John. Robert?
Thank you. Yeah, our experience at Mount Sinai, very similar to what was shared for Presbyterian and at Northwell. We did go virtual with the incident command very early on. We were following the models coming out of China, and in particular Italy. And so one of my teams is our clinical data science team, and they were responsible for part of the work that was done to kind of model and try and project where things were heading in terms of how many patients we would see, how many in the ICU, how many on ventilators. It was an incredible effort from our IT colleagues to everyone from our students who volunteered their time and rolled up their sleeves. And one of the interesting parts of my role is, in addition to the technology and innovation work, I'm the administrator at the Mount Sinai Hospital for our emergency room and our respiratory care services. So those departments, in particular respiratory care, played a big role in organizing our efforts to procure ventilators at a time when, since it's really a global supply chain, it was very difficult to try and make sure that we can secure enough ventilators to meet the anticipated need. And thankfully, we feel that we started that process very early on, and probably in part because New York was early, one of the first hit hard in North America. We were able to do that and procure, enough orders of our ventilators to make sure we never had to worry about a patient not having a ventilator when in need. We saw over 2,000 patients. Around the peak in April, we were seeing a new patient show up in the ED about every 6 minutes across our hospitals. So there was a tremendous effort to create additional capacity, create additional space and rooms, similar to what was shared previously. We were kind of figuring out how to we kind of took it day by day, and each day would figure out kind of what was needed and would mobilize where we needed to stay ahead of what we were projecting would be coming the next day.
Thank you, Robert. I know it was a tremendous undertaking at Warp Speed. So, again, I can't thank you guys enough for all the hard work you and your teams have done, making us all very proud. And I know also you relied a lot on your vendors and your supply chain folks. And so, Yuri, I know you were following us pretty closely as well and trying to add value and support. So why don't you tell us what your experience was?
Sure, and I'm actually going to talk from a different angle, more from the remote patients that are actually the positive COVID patients that are at home. So when we first started, by the way, I'm based in Israel, but we operate in our company, Datos, operates both in Israel and in the States, and especially, by the way, in New York. In the beginning, we didn't even expect to face something like that. Our company is usually, remote care is usually done for CHF patients or long chronic conditions like diabetes, hypertension, transition of care. In many of those cases, patients can opt in or can decide not to use the remote care services and still go to the regular standard of care. What happened here is that both in Israel and in the States, government officials and a lot of different stakeholders started to intervene in a good way in the company product. The Shiva Hospital, one of the largest hospitals in the world, actually put together in our design studio a remote care program for positive COVID patients that are at their own home. That program actually spread it across Israel and got contracted by the Ministry of Health. Then we moved into the States, and in New York, we had a few accounts that in a matter of days implemented that remote program. So everything would be done automatically. All the symptom management for the positive COVID patients were calculated and managed automatically for those accounts. And suddenly we started even to see accounts that we didn't even dreamt of, like the county health departments of specific counties in the state started to use our programs, and we never faced it. What was good in our perspective was that we as a company and as a high-tech company, we are used to work remotely. Even before the COVID, we actually 2 days a week worked remotely. So when it hit, we just in a minute everybody vanished to work from their own home, and actually the capacity and the utilization went off the roof. I actually had to tell my folks to slow down and to have a break in the middle of the day, but it was crazy, and it was a great experience.
Thank you, Tom.
Yeah, we had some similar experience to yours. We do have some remote working, or did have some remote working at Healthex, and when the situation started to get bad in March, we decided to go full work from home. Primarily because of the public transportation issue. The people weren't concerned about being in the office; they're concerned about getting to and from. We thought that was going to be a month, and we're still remote, and no idea when we're going to be returning to work. But I would say that and by the way, we did also support telehealth through our portal. We made some modifications so that our users, the physicians in New York City, would be able to access their patient records by getting consent from their patients over online rather than having to get it in person. But I'd say the two biggest areas that this affected us in were alerting our participants about their patients' COVID-19 status. So it mainly was alerting the tests and the results of the tests. So far, we've sent out 26 million messages to our participants just on the COVID-19 test. The second big area was the partnership we had with the departments of health, both at New York State and New York City, who needed this information in real time for their own surveillance and analytics. And we've sent now over 273,000 records to the Department of Health, with about 6 million updates to them on those patients' status. And I think that partnership with the city and the state has really been built up as a result of this work.
Thank you, Tom. Well, you guys can probably see I'm actually in my apartment here in Albany. We had to work from home from mid-March to mid-June. And what I think was actually kind of interesting about that experience was we really needed to be there for our membership across the state. And so we couldn't miss a beat. We're still on the 50-50 work at home, work at the office. And so today's my day to work at home, which takes me to my next question. So let's jump right in with the providers on this panel first. And I'm going to give you guys a little extra time to answer this question because it's kind of twofold here for you. So you had two extremely difficult issues going on with your IT staff, right? You had to support your clinical and other essential staff in a safe way, and providing care to very sick and very contagious patients. And the other was to support non-essential staff working from home. Tell us how you approached this and were able to pull it off so well. And let's start with you, Dan.
Thanks, and thanks for raising the question this way. I think the most important thing to focus on is how we supported our frontline workers. Given that it was the doctors and the nurses and phlebotomists and EVS and transport people who are really fighting the virus in our hospitals, we needed to give them every bit of support that we could. And so our IT teams, our biomedical teams, our analytics teams, we're all about supporting them, giving them the tools that they need, staffing up, ramping up, delivering new tools, creating new ICUs in every space that we could think of. If I think back to where we created ICUs, I mentioned out of ORs and PACUs. We even did it out of lobbies, cafeterias in our Queens hospital. We even took the Columbia University football practice bubble and turned it into a 200+ bed hospital. So we were certainly focused on doing whatever was necessary to support the frontline workers. And where we weren't doing our day job supporting them with technology and biomedical equipment, we were volunteering. So we had members of our finance and legal and HR and IT teams volunteering in our hospitals to be doing temperature checks or delivering supplies or relieving people from their jobs so they could get a rest. So it was all hands on deck to support those people. At the same time, every one of the provider organizations who's with us on the call today has a large back office team, HR, finance, logistics, IT, people who aren't normally in the hospital and didn't need to be in a campus somewhere. And like many other institutions, we sent most of those people home, and it was jarring we used to have anywhere from 100 to 500 people working remotely at any time. And at times we were at 5,000, 6,000 people working remotely. And we did that in a matter of days. And so people who'd never worked remotely before, we were spinning up Chromebooks and iPads and laptops and all of our inventory, configuring them, handing them to the people, making sure they were safe from an InfoSec point of view, and then sending them home and supporting them. And to their credit, we found that our productivity for our remote workers is as good as it was before. Now they're missing the training opportunities and the camaraderie and the collaboration that they get in the office, but we've used some tools in lieu of that. At the same time, we've been able to keep everybody safe and secure, and we've maintained our facilities. So all of our offices and even our back offices in Manhattan are open. So a number of us still come to the office every day, or some of us are in and out. So at the end of the day, I think of it as two large workforces. The clinical got every bit of support that it needed, in fact, more support than it ever had before. And then our back office team got exactly what we needed at the time. And then we're looking at how we think about remote work for the future.
Thank you, Dan. John?
Yes. It was pretty obvious early on that the staff wasn't going to be able to stay in our administrative office buildings. So from a remote workforce point of view, we were fortunate that we had actually had an exercise about 2 years before that. We called it the Hazardous Weather Program, where we had decided that we were not going to close the corporate offices ever again in the future, in the event of, blizzards and hurricanes and everything else that happens. And so we had issued new laptops to about 10,000 employees in corporate services, and had them home testing it and trying it periodically and exercising it. So when we needed to send people home, it actually went pretty smoothly. And we sent about 10,000 folks home very quickly. And we sent folks from our ambulatory network, because our 800 practices had mostly shut down. And so we had call center agents and front desk people some who got repurposed, but who all went home, and some administrative positions that were in the hospitals that all went home, and including radiologists in reading rooms, where we actually helped them take all of that very expensive equipment that they use and get it home. So it was a pretty busy couple of weeks at that point, but it went fairly smoothly. We repurposed a bunch of IT people to be on our help desk and had a dedicated number in for that, for the remote workforce, and really very quickly had everybody up and productive and I think happier. But the whole process of getting the remote workforce home went very smoothly, and I think a lot of people were surprised and impressed by that even. In terms of the clinicians, we just had to help them in so many different ways. We had to, many ways that we wanted to be able to get them results as we were doing COVID tests, PCR tests, and wanted to make it easier to get results out to patients and physicians And so feeding results into our Salesforce CRM that our call centers use, or to, we have a chat bot that we call Nora, that is an app that runs under Teams, because all of our physicians use Teams, and they use this chat bot, and it allows them to verbally query the EMR. We were able to get them results in that way. So, you know, a lot of things like that. We quickly realized that if the nurses had two-way audio video into every patient room, that they could monitor patients without having to go in there and use up PPE. And so we didn't have that in our hospitals. I don't know, some others might have that, you know, routinely in every patient room. We don't. But we did something very creative. We went out and we bought 5,000 Amazon Echo shows. Which is a really inexpensive solution because it's a consumer device. I think they're like $60 each. And we put an Echo show in every single patient room. And we used Fire tablets on the nursing stations, and the nurses could actually monitor what was going on in the rooms. And it saved them, like I said, from having to go in and use the PPE so often to go in for monitoring of patients. So we did a lot of things like that, where nurses were doing one-on-one continuous observation. We used Celaborate Hello 2 devices that have night vision and always-on audio-video, and we deployed those into the rooms during the crisis. So, you know, anything that would help with monitoring patients without them having to be exposed and going into the rooms. Physicians, it was a lot about getting results to them in easier ways, and you know, setting up the EMRs so that they could see guidance in the EMRs, because, you know, the guidance that our clinical advisory group was coming out with was changing almost every day, and we had to you know, get out to get that information out very quickly, very broadly across all the hospitals. We also repurposed about 4,500 physicians from our ambulatory network into the hospitals. Many of them hadn't used the inpatient EMRs before, and so we had to convert all of our classroom training to virtual training for those physicians to be able to quickly get up to speed on the EMRs. And we brought in about 2,000 agency nurses and physicians from around the country to supplement them. And had to very quickly get them trained. So we had, you know, special training that we set up. We had a special clinical call center that we set up only for folks who were not as familiar with the EMR, and we staffed that with clinicians that we have in IT. So, you know, it was just a lot of any way that we could help to make their jobs a little bit easier and a little bit more efficient. You know, were the kinds of things we focused on for clinicians.
Wow, impressive, John. Thank you. Robbie?
Yep, similar to our other presenters, you know, a large part of our workforce had moved to remote work. And so the people on site were really those who were directly involved in patient care, and then those who were coming in, volunteering, repurposed, coming in for, you know, specific needs and specific tasks. And so I'll speak to the supporting our clinical teams part of it. Very early on, we had pulled together our clinical leadership and started to think about, you know, what are some of the questions that would be really helpful for us to answer with data and with analytics to support the teams on the ground. And some of the things we heard, you know, included, could we predict, you know, which patients are likely to end up on a ventilator? Could we predict which patients are heading towards the ICU? Which patients are heading towards end of life, and which patients are, you know, getting better and getting ready for discharge and getting ready to go home. And so our clinical data science team very quickly through the month of March started putting together, doing the modeling and creating a registry. So as each patient came in, we were continuously collecting the data, training the models, and building these tools that we started deploying in April to support decision-making on the front lines. And so we were able to give some additional insights to our frontline physicians and our frontline nurses and have some continuous feedback on the tools that, you know, we were rolling out. Many of us within hospital leadership were here every day, was out there rounding. So we spent a lot of time talking to folks, talking to the frontline team, talking to our physicians, talking to our nurses, hearing about how we could best support them. And in addition to all the amazing work to support the mission critical, our EMR and the additional beds, and to keep the clinical work flowing, there was some other efforts I think are worth highlighting. Similar to the Amazon project, we ended up with a partnership with Google, and Google basically said to us, listen, we're here to help however we can. Our need was having visibility into patient rooms. So with our infection prevention precautions, with these rooms being negative pressure and the door being closed, there was no visibility. And this is something our nursing team had been asking for. And so we ended up Google ended up sending us these Google Nest consumer grade devices. And very quickly, we started working with our engineers and developing a purpose-built console for us to, in a compliant, HIPAA compliant fashion, remotely monitor patients. So we had the ability to basically stick these cameras to the wall with a magnet, and we can get an entire inpatient unit up within a couple of hours and have a remote monitoring console using one of our standard kind of workstations and a Chrome browser, and have a member of the nursing team have visibility across the unit and have two-way audio, one-way video communication, which was tremendous and helped our team feel supported. We know that some of these patients would quickly take a turn for the worse, and so we wanted to have that continuous visibility on our patients. Remote monitoring as well, we ended up scaling up a large remote monitoring program of over 1,000 patients where we would put a wireless SpO2 device, a device that measures your oxygen saturation by sticking it onto your finger. We partnered with a company called Massimo, and we were able to stream continuous vital signs and pulse and oxygen saturation from in the room to a monitor right outside the room. And so scaling that effort, very quickly, and also having the ability to capture that data and start mining that data to identify trends and be able to build models to really identify early if a patient is taking a turn for the worse. So these were a few ways that we were able to really support the frontline team. There was other efforts related to our visitor restrictions. So, for a period of time, there was basically no visitors at all allowed in the hospital. And we were able to partner with Zoom and provide hospital managed tablets to patients and set up what we would call virtual visits. So through our patient service center, we would schedule visits between patients and their family members. And in some cases, this could be a mom delivering a baby where for a period of time, we couldn't have the loved one or the partner, in the room, and or just any other kind of contact or visit between patients and their loved ones. So we were using technology to connect patients at a time where it's very difficult for families since they couldn't physically come and be in the hospital and be with patients. So those were just some of the ways the team really came together to help support the COVID response.
Wow. I have to say, you guys have taken, in terms of what you had to do, HIT professional to an entirely new level. I really sincerely mean that. While at the same time, you've had personal risk associated with this contagious disease for you and your staffs. And so there's no more fitting term than hero for that. I honestly believe that, and just want you to know that. So let's go to our non-healthcare providers on the panel. So you had two different issues as well. One was keeping your business going, operation from home, assuming you were deemed non-essential. And the other was supporting your healthcare providers and their customers as customers. Tell us how you approach these challenges and if there were any unique things you had to do to pull this off. And Yuri, let's start with you.
Thank you for the question. So actually, we are an essential vendor, and in that sense, there is no issue. And as I mentioned before, we moved working from home like entirely in one day. And also on that front, there wasn't any issue. On the other side, like I had to put together some processes for putting down the number of meetings, back-to-back meetings. And you can think about it. I'm traveling like abroad like every month, sometimes twice a month. The commute to the office. Think how much time we're saved, and all this time went into productivity, into our product. So basically, what we had to do in the COVID scenario. And let me remind you that what we do is we actually monitor COVID symptoms for patients at their own home prior for them being coming to the hospital. So all of a sudden, we had to start enrolling patients when basically remotely. So if you now have a program, usually you enroll patients inside the hospital, like when you're in a transition of care scenario. Now we have to enroll patients remotely. So everything with regards to how to engage patients remotely and how to make them download the app and all the wording around that and making sure that they understand and do we track geolocations or we do not, and what we do with the information. All of that issues were super critical, and we had to deal with them quite a bit. Well, one of the things that I also mentioned before, but I would like to double click on that is the opt-in. Now, there's no opt-in choice when you monitor positive COVID patients at their own home. I need to monitor everybody, so also the elderly and also people with disabilities. And what we end up doing is we end up adding a lot of features of usability into the platform. So we can cover almost 100% of the population that were the positive COVID population. So for example, we added IVR for people that don't have smartphones. We had to add the ability to manage a household. Sometimes there's only one smartphone in a household. So how do you manage that? We added a lot of capabilities for nurses that using our platform and basically take the readings and the symptoms via the phone and logging them into our platform. Because again, not everybody have smartphones. So there are a lot of usabilities, functionalities that we had to add to our platform. One of the biggest thing that I would like to that left me with an impression is the with the county health services, they have to monitor the quarantine, and we had a big debate about the geofencing, and that was like me as a founder of a health company. I never thought that I will be facing that type of a dilemma, and it was quite an experience, I can tell you that.
Thank you, Yuri. Tom?
Yeah, I think that everyone's been surprised at how little impact the remote working has had on productivity, and we've certainly seen that. If anything, people have been working a little too hard and not getting enough of a break, and I think people are really missing out on the personal connection. So I hope that we will be returning to office, if not back to normal, at least partially, because I think that's something that's a little less tangible, but is missing, and it could be down the road consequences. The other thing that's kind of interesting silver lining about this is that we're now video conferencing all the time, and we've been meeting with our clients regularly on various things, but nobody thinks to turn on the camera. Well, now suddenly we're doing that kind of as a common process, and ironically, I think we're seeing our clients more because of that than we were before, because we wouldn't take the trouble to go see them, even though it's only a subway or taxi ride away. As far as things that we're doing differently, I mentioned earlier we've sent out about 26 million alerts so far on people's COVID status. The thing that I would say is distinctive about that is we were able to do that in a week's time. We were able to set that up and implemented in a week's time. The reason for that is we already had the infrastructure in place to send alerts to 728 of our participants. Were already getting alerts of one form or another. So we just kind of tacked this onto that. The other thing that expedited it is that the Department of Health has been extremely nimble on approving things during this crisis that normally would take months or years to do. So when we went to the state and said we'd like to push these alerts out without consent, and New York State's consent policies on sharing data in HIE are pretty restrictive, we had an immediate response, no requirement for anything in writing or anything like that. So that happened very quickly. Another thing that we'd been doing before but got implemented at record speed was allowing the Office of Emergency Management, Preparedness and Response at the city to use the HIEs in New York to respond to questions about the whereabouts of missing loved ones. And this was triggered originally by 9/11. It's been set up as a kind of a state of emergency tool, and it was invoked by the mayor during this crisis. And this tool was used to find 62 missing persons. Unfortunately, 38 of those had expired. But this is a case, in this crisis, there were people who were not able to reach their grandmother or some other loved one, and they didn't know why, and this was a tool that helped them. We also did work with the field hospitals, and for example, the Northwell set up a field hospital at the Javits Center, and we were able to support that by getting the users for our portal set up and provisioned to support that work.
Thank you, Tom. So I think it's safe to say that this experience really has changed us all in profound ways with respect to our personal and our professional lives. And in many ways, it has really made us even more reliant on technology, and that's what we do. So I have kind of a two-part question related to all this, and kind of want to drill down deeper into some of the technology aspects of this. So I want to talk about what tools and technical procedures that are in place now that will change your approach if a second wave of COVID comes. And then also, how have these tools become more of a long-term solution in terms of your overall strategy? And can you also explain what kind of problems these new solutions have solved for you and as you've learned and gone through this? And then also want to kind of talk to the providers about, has this digital health telemedicine strategy changed in fundamental ways now that you've learned how these new solutions can really apply? And are there new specific technologies or platforms that you are looking to implement that were on your radar previously, but now are really important because your patients are probably more receptive to doing it because they are probably looking for a more safer way to receive their healthcare through telemedicine strategies. So I apologize for the long-winded question, but I think you guys know where I'm getting at. Let's reverse this order. And Tom, if you could talk a bit about that in terms of what you've seen in terms of this new paradigm shift into leveraging technology in healthcare.
Yeah, one of the interesting things we're working on right now is Healthex, in addition to providing products and services to our participants, also partners with third-party vendors. We find that their innovation exceeds what we're able to provide, or is more focused in a particular area that we haven't been able to explore. But our data can help their application be more effective. One of the vendors that we're working with is putting out an app that would be used to access their own COVID-19 related status. And the use case for this is to gain safe entry into work or school, or even potentially a public venue like a Yankee Stadium or Broadway. It's a very simple app. Their app calls they have to do the ID proofing, of course, to make sure that the person is who they say they are. And then their app calls an API on our side and gets back COVID-19 test results, antibody information, and I hope very soon immunization records that they can then display. We've been working with an analytics firm called MProbe for quite some time on predictive analytics. But they have found that an ability to detect Kawasaki disease, which turns out is related to COVID-19, and this is a critical early warning system because Kawasaki disease can easily go undetected in a child, and if it's allowed to go on for even days or weeks, untreated, can cause long-term mortality during adulthood. So we're excited about rolling that out. We've been working with the Department of Health on a project called New York Leads, which was originally envisioned to use a third-party vendor to early detection again for antimicrobial resistant infections, diseases like MRSA, which can be devastating when patients move between nursing homes and hospitals, to try to catch those and stop them quickly. That recently has been expanded to include COVID-19 as well. And then finally, we were approached by a group of informaticists and IT people at Northwell who developed their own surveillance system for identifying outbreaks quickly so that they can be located and the contact tracing can go into effect and other activities. They were successful in implementing that with the Northwell data and reached out just to expand it to make it a New York City wide capability. So we're really excited to be partnering with them on that.
Thank you, Tom. Yuri, let's go to you.
So from our perspective, we do provide remote care services and virtual visits as part of our platform. And I do think that especially the virtual visit, Zoom-like technology will become more and more commodity in the near future. And the same way that we integrated that into our platform, many other technology vendor will have that capability, because there are different use cases that you're going to use virtual visits. Not always is going to be the same use case where you have in a clinic a physician that's doing both in person and virtual. There are many other use cases for that technology, for that virtual visit technology. What we've seen, by the way, on that front is that during April and May, there was a tremendous peak, and I'm sure that my colleagues here can also talk about that. Tremendous peak in the telemedicine services. And then, and I'm talking about New York, by the way, and then you can see a drop. And we wanted to see that drop goes up in the second wave, and from some reason, I'm not sure that I fully understand exactly the trend and how it works. Again, I'm happy to hear other opinions here on the panel, but that was quite interesting because people are not going to hospitals, and a lot of hospital services are being transformed to be remotely. But the idea is why people are going back now, or to what level we're going to go back to the previous situation. That's a question that I think that no one has an answer at the moment. Even when I'm dealing with that is quite an enigma for us. We do, by the way, we have places around the world that are facing the second wave right now, and it's also interesting that you don't see that same peak that we saw during April and May. Some of other technology that I mentioned before, but also I would like to add to that. We added the capability of communicating for patients to communicate with their care teams and physicians and nurses without the need to download an app. And saving that task that for us maybe, or for many of us, looks very simple to download an app and start using that to manage your health. You would be surprised to know how, but this is a barrier for such a large group of people, especially when there are a lot of people that are staying at home and they don't have their kids or people that can help them to download an app and show them how to use that. So the ability of doing a lot of things without an app, to fill a survey, to go into a virtual visit, that's something that we learned that can help tremendously, especially in cases like COVID, where scale is everything. And Robert just mentioned the put a pulse ox on each one of the patients, and they did it inside the hospital. What we found out is that when you're talking about scale, there is no way to use connected devices. So only in severe cases, usually those cases would be moved quite rapidly to the hospital, but only in severe cases there were connected devices integrated into our platform. In other cases, we had an image analysis with machine learning where we took the reading of a non-connected device, much more scalable from a price perspective, and with image analysis, we upload that data into our cloud and move and put it into our algorithms for to drive the health score for each one of the patients. Thank you.
Thank you, Yuri. Robbie?
So I think so many of the technologies that we were really focused on during the first wave of COVID are going to continue to scale and persist and stay with us for a period of time. I think, certainly we continue to use the remote monitoring platform we developed with Google. They've offered this for free for other healthcare organizations as well, if anyone's interested in that work. Certainly the AI tools that we built to support the COVID response, we continue to refine and retrain and improve upon. Some of the other things that we were focused on during the first wave included contactless meal ordering. So, one of the challenges we had is that we didn't want our catering associates kind of going in and out of each room, potentially putting themselves at harm and also spreading, potentially spreading COVID. And so we've been really focused on scaling up our electronic meal ordering. That way, patients can pull up their menu, order a meal like, as New Yorkers, we love to do on Seamless or Grubhub. We want to kind of offer that, same experience to our patients. We're working with Seaboard, our vendor, on that initiative. Also our patient portal. So we're primarily an Epic shop, and we use our, there's an inpatient kind of view we can show when patients are admitted called My Chart Bedside. And that gives our patients and also their proxies, their family members, the ability to have a really granular picture on what's going on. So they can see at any given moment, who's the nurse caring for me and what do they look like? We include care team photos because in an age where we're all wearing masks and you can only see kind of half of our faces, we think that it's very very patient forward thing to do is to make sure they can see kind of who's caring for them. So photos in real time of their frontline nurse, frontline provider, the rest of the care team, and try and show that in a very patient-friendly way. Show things like what is on their schedule for the day, what medications are they on, and push out different types of educational and interactive content through that portal. And I think that will continue to grow, and that'll continue to be a tool that we use, and not only think about as kind of an outpatient tool, but also can be used works very well on the inpatient side. I also think that there's been a bit of a change in breaking down some of the silos that traditionally existed within academic medicine. A lot of folks from our research community had done tremendous work supporting the response. From our virology labs that were working on antibody testing, to our teams working on convalescent plasma, to our folks working in data science and analytics. And so at Mount Sinai, we created the Mount Sinai Center for Clinical Intelligence to really be that bridge between our researchers working on data products and the hospital, and come up with ways that we can cross that operational gap that often exists when a researcher builds something in the lab and writes the paper, but it doesn't always get operationalized. And so one of the big projects that we've been focused on is our Warrior Watch program. So we've provided Apple Watches to a large group of our employees, and we are testing things like the impact of the stress of COVID-19. We're looking at, is there a signal in things like the heart rate variability that can tell us early on if someone has been exposed to the virus, even before they know or go to get or have their test results. And so I think these types of programs where we're using remotely monitoring and able to collect data back, from smart devices, from wearables, are going to be so integral to the way that we work moving forward. We had an existing hospital at home program where a patient who, let's say, shows up in one of our emergency rooms and needs an inpatient admission, we will, instead of admitting them to the hospital, admit them right to home, and they'll get the same level of care at home. And I think that the ability to set up platforms where we're getting that data back from patients' homes, and even at a less acute level, just population level remote monitoring of patients with heart failure or patients with some sort of respiratory disease, for us to be able to get back information and have these remote monitoring and condition management programs. Now, because of changes in the funding landscape and changes in just how easy it is for us to get that information back, I think that that's going to be just an integral way of the way that we do business. So I think, to your question around new platforms, I think that many organizations had their kind of established or telehealth platforms, but I think new platforms coming down the line that I can imagine will be more in the remote patient monitoring space and really building out kind of capabilities in that space. Thank you.
Thank you, Rob. John?
Sure. Well, in terms of tools and procedures that now exist that we can utilize for a second wave, I think each of us could probably speak for an hour about that, because we all did so much and learned so much. One of the things we do whenever there's an event of any kind, an emergency event, is we keep really close track of everything that we did in IT, and we call it our dossier. And the dossier for this turned out to be about 25 pages long. And we extract out of that, once things calm down, lessons learned from everything that we did, and then we extract out of that actionable items. And we've been working on those actionable items to prepare for resurgence. We have been rehearsing it. We've had system-wide EOC rehearsals. So I think things will be very different. For IT, we'll be ready in a whole bunch of different ways. We've got biosurveillance tools now that are in place that'll give us much earlier indications of problems that are occurring by zip code. We've got a centralized logistics center in place. One of the keys for us in managing this crisis was to be able to load balance our hospitals. And so we stood up a central logistics center that had visibility to the ER and bed census of every hospital, and they don't all use the same EMR and the same registration systems. But we had to know when some of our hospitals were in trouble and were getting overwhelmed, and line up ambulances outside of them and take patients who were stable enough to other hospitals. So that was a constant. I think we transferred a total of about 1,000 patients during the 4 worst weeks of the crisis. And so that central logistics center now was really key. It'll be key again. It's stood up, it's ready to go. But it's also going to help us in the future in terms of the normal transitions of care out of the hospitals and into the post-acute world or whatever, and being able to more standardize the way that happens around our hospitals, and utilizing the central logistics center, which I think in the future will really do complete bed management. But we have the biosurveillance tools. They are linked to predefined surge plans now, so we're not going to be creating surge plans on a day-by-day basis. Our systems are ready. All of the things that we did in terms of data and analytics and predictive models and research things, call centers, chatbots for our call centers, virtual training, visitation devices, everything that we did, it's about 15 or 20 different major areas that we really enabled with technology. All of those things are ready to go, and so I think it'll be a much more structured and organized for us resurgence if that were to happen. I'm not going to go over things people mentioned already about home care and remote monitoring and all of those things, but clearly telehealth came of age in the pandemic. We were doing 50 or 75 telehealth sessions a week pre-COVID. Very, very quickly, that became 5,000 a week. And so that had to get ramped up very quickly. It wasn't without bumps, but it, you know, it was the safest way for patients to get certain types of care. So clearly that is here to stay. Our numbers are coming down, and we expected that they would. You know, we expect that they'll level off to, you know, 12–15% of our ambulatory visits being telehealth for the next couple of years anyway. And so making that function better, making it more convenient for the patient, making it more in the normal physician's workflow. And so the way that we had set it up was that it's very integrated to our scheduling systems. It's just another visit type, happens to be virtual, integrated into the EMRs and in our billing system as well, because we don't want physicians pulled out of their normal workflows as they're doing telehealth visits. So I think a lot of these things are here to stay. Digital health as well, and, you know, making it easier. That's something that I think has just been accelerated during the crisis, and because of the crisis, making it easier for patients to get information and navigate our health system and so on with mobile apps and things like that. I think some things got accelerated, some things came of age, but I certainly feel that, and I'm sure the other presenters as well, we're more prepared for a resurgence than we were, and that's a much better feeling than inventing it day by day as you go through the crisis.
Well, thank you, John. That's actually very encouraging to hear. And it's, by the way, it's good to see you. Glad you get your cam working.
Yes.
Thank you for that. Dan?
Yeah, I think this question is summed up well in one of the Q&A we got asked by one of the participants, Mary DePasquale. She asked, how do you address the challenges of deploying new features and technology within an extremely condensed timeline for development and testing? Is it easier to build in-house or purchase a product and integrate? And how do you get clinician buy-in for doing it rapidly? You know, I think everybody on the panel has described great technology that we rolled out during this. And I think some of the ways to make it successful were about being simple and doing it quickly and going deep with tools we have already. So I'll give an example of each. Simple. So we talked about the incident command center. And I think John talked about people becoming infected, thinking about whether to hold them physically or virtually. Early on, we said, you know, our command center was this room, screens and whiteboards and pens and phones, and that was the old way of doing it. Now our incident command center is a Zoom meeting. It's a standing Zoom 24/7. We call it the virtual command center, the VCC. We started using it during the crisis, and we still use it. We still meet once a week on the VCC, and it's stood up all of the time. We had a issue in one of our ORs with a facilities issue a week ago, and we used the VCC as the way everybody responds. So the simple, just using the tool we had already, Zoom, and just reimagining something we used to do, the physical command center, is the simple part. The speed, and this gets to Mary's question, how do you get something like this done? And remember, in the crisis, when our ED physicians were, you know, on the fence about whether to send somebody home with a pulse ox of 93 or 94, and they really wanted to admit them, but we didn't really have enough space to keep doing that. So we ordered 5,000 easy off-the-shelf pulse ox monitors, taught our patients how to use them, sent them home, and then organized oxygen to be delivered to their homes. Very simple, low tech. It involved everybody understanding what they were doing, but in that way, we were able to meet a need very quickly and clinically, and use technology that we already had and not try to do anything very complicated. To Mary's question, clinical buy-in, because the ED docs were like, great, I'm really wary about sending this patient home on a 94%, but if you tell me she's going to have pulse ox monitoring at home and we'll come right back if it goes below 92, I'm comfortable. So that's simple, and then there's speed, and then there's deep. You know, we already have all this technology. Now's not really the time to be rolling out something new. How do you go deeper with what you have? So whether it's a workforce management tool or our EMRs, just going deeper and using the full functionality is, in my opinion, better than trying to add something on. And I'll wrap up by saying, I always think that healthcare is 80% people, 15% process, and only 5% technology. And I think we saw through the COVID crisis that it wasn't about the 5% technology. It was really about the people and the process that make up 95% of what we do, that we were able to save lives and support our clinicians in fighting the virus.
Great point. I appreciate that, Daniel. So, guys, I want to go off script now, and thank you for taking that question, Daniel. I think that's really good, and thank you, Mary, for submitting it. We've got about 138 people on the call, and we're already past our first hour, and I wanted to go off script and start to field some of the questions, Sebastian, if that's okay. So let's start with Mary's question about, is something you build or something you have to, find and integrate? So if any of the other panel members would like to take that, let's go there. So who would like to handle that? Okay. All right.
Roy, what is the question?
The question, why don't you read it if you could, Sebastian, for us again?
All right.
It's from Mary.
Yes, the question from Mary De Pasquale. How did you address the challenges of deploying new features and tech with an extremely condensed timeline for dev and testing? In an urgent situation, is it easier to build in-house or to purchase a product and integrate? What methods help you maintain clinician buy-in for rapid technology changes?
I mean, I'll comment, and I think Dan, did touch on it. But it's both. It isn't all one or the other. I think one of the things that we learned during the crisis was the importance of vendor relationships, and that the ones that were the longest term relationships proved to be the most valuable. And so we needed to lean on Apple and Amazon and even some of their developers that we had working on some of the solutions that we put out, or we wouldn't have been able to do it. And yet some of the things that we needed to build, and even processes that we needed to build with surge teams we split into A and B teams who worked 12 hours a day, 7 days a week, putting up surge units as quickly as we could, and some of the technologies and tools that they used to do that. So it's build by whatever makes the most sense. I don't like building things that I can buy. I like building things that need to be unique to us, and this way can be more tailored to us. But so I don't think it's one or the other. And as Dan said, we had to get used to doing things a lot faster. I think that has raised expectations. I can't keep people working 7 days a week forever. And that's part of why things were getting done faster, because people were working more hours. But it did show us that there is an expectation that solutions can be churned out faster. And that's just something that we have to get continuously better at doing through agile transformations and other ways of just delivering iterative updates and features and functions as we go along in order to meet what is definitely a heightened expectation on how quickly we can get something out the door.
John, I can't agree with you more. I've often said technology's got to work, it's got to be good, but the people behind it have to be great. Otherwise, it just doesn't work. So thank you for that answer. Would any of the other panelists like to tackle that question?
This is Tom Moore. I just like to agree with what both Dan and John were saying. Our meaning specifically that investing in brand new technologies is a tricky thing to do in the midst of a crisis. So we have depended more on our existing technologies and modifying them to support the crisis, and also working with the third-party vendors who are providing tools for population health and remote patient monitoring that are more agile and have more bandwidth than we do to address these specialized needs. So we can help them to make their applications more effective by providing the data to them, which is something that we are very used to doing. And so that's a well-worn path for us.
Thank you, Tom. Anyone else like to address that, or should we go to the next question? All right, Sebastian, why don't you read the next question?
Sure. So the next question we have is from someone who's anonymous. The question is probably for our providers. Once a vaccine becomes available, what is your process for distribution? How can IT play a role, and what gaps do you see?
Good question.
Ooh, this is John. That's a tough one. I can answer for New York State. New York State doesn't know how they're going to do it yet. We have a team of 7 people that are up in Albany today. We have a very close relationship with the governor because his father, previous governor, our CEO, was his health commissioner. And so we've remained very close to the Cuomo family and work day in and day out very close with them. And he has asked us to come up to Albany and help them figure this out. And so I don't think there is a plan yet for vaccine distribution. We know it's going to be complex. It's not going to be like flu vaccine distribution. You know, these could be 1 dose, 2 dose, have to be frozen at -7. It's going to be very challenging. And I don't really think, and I'm sure the rest of the country is like New York, I don't really think there's a definitive plan in place right now for how that's going to be done. But I think he'll be counting on the biggest health systems in the state, most of which are in New York City, to play a role in helping to do that.
Thank you, John. I also can tell you that Haney's is also engaged in this conversation, so a lot to follow on that. Would any of the other, Dan or Robbie, would you guys like to talk about that in terms of what you're doing to gear up for that when that day comes? Or any thoughts?
I think John did a nice job of outlining that we're all prepared and we're looking at different methodologies and processes. We're making sure that we've got the right physical capabilities for storage, but at this point, we're all just in preparation mode.
Great. Okay. Sebastian, next question. Sebastian, you're on mute.
Sorry about that.
Okay.
This question is from Bill Blewett. What active steps have the health systems taken to share and trade best practices, engage in collaboration, derive insights together to advise public health leadership in the city? Any obstacles or barriers to collaboration during the pandemic?
Who would like to tackle that one?
So I'll jump in first. You know, this is where we're stronger together. So our CEOs, at least in the New York metropolitan region, meet frequently to address public health crises, and this was no different other than that they were meeting more frequently and comparing processes and tools, especially as it concerned or responding to growth in specific areas, and then use of public health resources like Javits and USNS Comfort. And then a number of us who were supporting the plans for moving out of the crisis and into reopening facilities were coordinating, sharing data, sharing trends. And so we were trying to keep each other informed of what we were doing as best practices. I think it was a great example of working with New York State amongst the health systems, with the New York City government, and with Haney's, who were all deeply involved in coordinating this. So I'd say it was open and transparent in sharing data and best practices.
Great. Anyone else want to add to that? And again, today is another example of these folks taking time out of their very busy schedules to share what they've learned. And so hopefully this also helps to drive that sharing of best practice. Anyone else want to tackle that? We're going to move on to the next question.
Well, I'll just add that I think, across the board, it's really broken down some of the, it's really enhanced the collaboration between, different entities in the region. And, I know everything we've created kind of my team's worked on the data science analytics side, we've published, we've shared publicly. I think there's been lots of forums like this where people have shared. I think I'd mentioned before the work we did with Google. We're making that available, and many health systems around the country have taken advantage of the platform we created and using the cams. So I do think that it's enhanced the level of collaboration. I also think it underscores the need during a public health emergency for us to work as one connected healthcare delivery system, and that no one health system can really do this alone, that we really all have to work in collaboration, because there's so many interdependencies on each other during a public health emergency.
And I can tell you, for those that saw the governor and gave us press briefings every day talking about the need for us to look at ourselves as one big system. And I can tell you firsthand, seeing it, the evidence that actually occurred. It actually occurred at a pretty high level. So again, another really impressive thing that happened here, that these systems could come together, the hospitals could come together and really work as a team on this whole process. Sebastian, next question.
All right. So the next question, I think, was alluded to when folks gave their answers earlier, but I don't think we've had a focused question on this topic. So anonymous person has asked, how has automation enabled you to respond to the challenges of COVID-19? And how do you see automation playing a role in the future?
You want to take that?
I can take that.
Thanks, Drew.
I think that again, I mentioned that before. Scale is something that we all faced during the COVID pandemic, and automation. From our perspective, not only that the Datus is a remote care automation platform, but in general, we entered a lot of automating procedures. And the main use case that we dealt during the pandemic is a group of nurses in an outpatient ambulatory environment, trying to manage hundreds of thousands of positive COVID patients at their own home and managing their symptoms, trying to understand which one should be evacuated to the nearest hospital. So all of that process basically was automated with not only symptom surveys and measurement uploads that were done automatically with the system and the patients, but also all the gathering all this information into one algorithm, calculating that health score that helped the nurses to basically understand with which patients they need to go on a video call to better assess their situation. So that's one thing that we faced in the sense of automation. The second thing actually just came recently in the last, I think 3 months. We've seen a lot of from health organizations like hospitals and outpatient clinics. We moved into health plans and employers and back to norm. And all of a sudden, how do I follow the CDC guidelines and making sure that all my employees are entitled to go back to work? And then we are now working with health plans, and then again, automation comes into the play to understand how many case managers do I need to hire to have a whole university go back to norm in terms of symptom management and following the CDC guidelines. And also in those situations, automations played a major role and reduce the number of the case managers and make those solutions much more cost effective. So that's my perspective about automation during the COVID crisis.
Joe, if I may, there's a follow-up question on the automation, which I think is a good pivot point to our providers if they want to tackle this topic. So my HIMSS colleague Armand asks, how have you increased your use of automation in light of needs around cost reduction and reduction in redundant manual processes? So over to you, Joe.
Anyone else to take that on? Oh, maybe not. Go for it, Rob.
I'll just mention, well, I think that, in a post-pandemic world, we certainly want to move away from, some of the things that we were very slow to adopt in healthcare. So, the fax machines, the paper-based kind of processes where, you're handed a clipboard and filling out paper and you're passing those papers around to various folks doing data entry. I think there's the opportunity is ours to kind of optimize that process and patient experience as well. So I think being able to have automated processes that can pull in that information, less paper-based workflows, less manual kind of data entry. And I think that's starting to happen, whether it's electronically signing your forms kind of on your smartphone or on a tablet, electronically entering information before you come for an ambulatory care visit or an acute care visit. I think that can help eliminate a lot of these paper-based processes and naturally get us to kind of a more efficient future state. And there's cost savings and less paper and less resources that are needed to that we could free up to do higher level work. So I think that's clearly where we're heading. I don't know that we're fully there yet, but that's clearly where we're heading.
If we could, guys, with the last 8 minutes we have left on this call, I'd like to take this last question on because I think this is a real important one that we've talked about. I know for all of you, and it's clear hearing what you had to do and what you had to endure, and these were long days, I know, that this all impacted you both in a very personal and professionally profound way. So with the last time we have, if you could kind of keep your minutes to 2 minutes each, or 1.5 minutes, can you tell us what the most valuable professional lesson and thing you learned about yourself through this? And if it's okay, Dan, if we could start with you, that would be great.
Sure. Well, first, thanks for hosting this and for everybody on the panel for sharing today. I think I learned most that focused together, our team can make anything happen. So there were some very dark moments in March and April, and our team's clinical, IT, operations, finance pulled together, and we worked well in a crisis, and we made things happen fast. So within a number of hours, when we were confronted with the problem, we were able to solve it and move on in a way that our health system, and I think most people would admit, other health systems just can't normally move that fast. So faced with a crisis, we all do what we need to, and the right people step up, and it was really heartening.
Thank you, Dan. John?
Couldn't agree more with Dan, and I would absolutely have that as my top 1 or 2 lessons learned. For me personally, we're in healthcare. And so, we have a special responsibility and a special obligation to lead through crises like this. And you can't be in our positions in major health systems in New York City that millions of people depend on, and where, it's a difference between life and death, how good of a job we do and how many patients we can treat during a pandemic like this. So, it's got to come from the heart. And you have to understand that I've got 2,000 employees that are counting on me. So communication was so essential, not just to coordinate everything that was going on, but also for me to be able to say to my employees, we're going to get through this. Stay optimistic. We kept talking about the peak. When are we going to be past the peak? Well, I needed to be the person that was telling them that we're going to survive this and we're going to get through it and we're going to get past the peak and everything is going to be okay. I didn't even realize at the time how important that was to them until I got feedback from them afterward. And we have a lot of doctors and we have a lot of nurses that are counting on us as well. We have a lot of peers that are counting on us as well. So I just think that, if you're in healthcare and in a big health system and in a big place like New York City, you come to the job knowing that those are responsibilities that you carry, and that when the crap hits the fan, like it did in this case, that we have to rise to the occasion, we have to rise to the challenge, and then we just have a lot of people that we would be failing if we didn't do that.
Thank you for that answer. It's all about leadership. Very good. Rob?
Yes, I completely agree that it was just amazing to see how everyone came together so quickly to support the response. I think, one thing that was so important was having the continuous kind of feedback from our teams on the front lines and our teams in all of the supporting services, across the health system, and to take that iterative approach where we're continuously kind of listening, adjusting, improving, getting better, and that continuous kind of iterative cycle. I think just kind of looking at the next thing we have to do, the next task, and getting through it, I think was so important. And the other I think lesson learned from me was really kind of, you can't underestimate the need after we've been through something like this for just wellness, giving people a time to stop, to reflect, to kind of talk about, what we've all been through. We do sessions with our spiritual care team here at the hospital. We have a therapy dog that comes and spends time with the staff, and, sitting in on the sessions with our spiritual care colleagues and our team was just so moving, and giving everyone a chance to just talk about what they've been through and reflect on that, I think what was so important. And so was, just even helped me appreciate even further just the amazing effort that took place and that folks led across all the different aspects of our healthcare system.
Well put. Yuri?
Thank you for having me in this wonderful session. So I think that again, I'm coming from a different perspective as a CEO of a for-profit company that actually dealt in the COVID crisis quite a bit. I think that the most important thing that I learned is to be modest and humble. You don't know what you don't know and how it's going to evolve, and reflecting and taking a little bit of time to understand what is going on, but is nothing like whatever I learned and whatever I experienced before. I think that's one of the most important things that I learned. The second thing is quite obvious, but it's never been more true. Agility. The ability to understand and react is so important, especially in cases like that. And the last point that I think that everybody mentioned here is leadership and consensus building around the team. It's not a one-man show; it's a team effort, and a team needs to have a leader to follow. So leadership and consensus building around our work is so important in time like that.
Thank you, Yuri. Tom?
Thank you. Well, I've learned that I miss going to the office and I don't like working from home all the time. But the other thing is that I've been doing this since 2009. And when we started this public HIE concept, it was really kind of a fun project that came out of the Greater New York Hospital Association. And since then, I've seen it evolve to something that's more and more integrated into the healthcare community in New York City. And this crisis really drove home the essential nature of having a public HIE. It's critical that everyone in healthcare knows what's going on with their patients and where they are. And I think that that experience, that lesson will probably stay with us after this. So that's I think maybe the silver lining of this for us.
Well, thank you, Tom, and thank all of our panelists for doing a great job. It's been my pleasure and my honor to work with you on this, and hopefully all of you viewing got as much out of this as I did. So with that, I'll turn it back over to Sebastian.
Sorry, my mute button's a bit slow. Thank you so much, Joe. Thank you very much on behalf of New York HIMSS to all of our panelists. I just want to remind our audience today that if you're not already a HIMSS member, we encourage you to join as a New York HIMSS chapter member at hims.org. That will help fund our organization and allow us to put on more events like the one today. Our next event is on November 12th at 5:30 p.m. Eastern on the topic of nursing innovations and stories from the front line for this year. And if you want to see our full events calendar, please visit the New York HIMSS chapter website at nyshimschapter.org. Thanks again to everyone for participating today.
Thank you.
Thank you. Bye-bye.
Thank you all.